So we'll be talking about autofluorescence imaging, which is a complement to existing imaging modalities like fundus fluorescence angiogram, color photograph and ICG angiography, and should not be seen by itself. So what is the basis of this autofluorescence imaging? Essentially, autofluorescence images the lipofuscin. Each RPE cell phagocytoses some 3 followed by 9 zeros of outer segments in a lifetime. So whenever you overeat, you tend to accumulate cholesterol. Similarly, the RPE cell accumulates lipofuscin, and when this accumulation is not able to be matched by the clearance, then lipofuscin builds up, and this lipofuscin is what we image on autofluorescence. And lipofuscin accumulation is a hallmark of aging in metabolically active post-mitotic cells. And this lipofuscin is autofluorescence. And autofluorescence in return is an indication of the health of the retinal pigment epithelium. And the other fluoropores and disease of autoretinal and subretinal space can be imaged by the autofluorescence. The fundus autofluorescence imaging is simple, non-invasive, we don't have to inject any dye. It gives additional information to FFA, ICG and OCT images. The principles are, we stimulate the eye with this wavelength of light, and the emission is this 480 to 800, so it's a very, very large range, and it's maximal between 600 to 640 nanometers. And fundus autofluorescence image are 2 orders of magnitude lesser than FA. In the sense it's less brighter. That's why I asked him to turn off the lights, but there is some leaking light, so we may have to strain a little bit to see the images. And there is autofluorescence from other intraocular structures like the lens, which may alter the image you get, and that's why modification of camera equipment is required. Fundus spectrometer was the initial equipment, nobody uses this anymore. The SLO, the Heidelberg, which Dr. Hemd was talking about, is also an equipment which allows us to image the autofluorescent images. SLO is confocal, so it avoids autofluorescence from other structures, so it gives very precise, good images. And the excitation in SLO is using 488 nanometers, and barrier filter is 500 to 521 nanometers. And it occurs multiple images and averages. You can use a fundus camera. Some of the fundus camera, like the top hand camera, allows us to take the autofluorescence images. Here it's just a single flash and it collates one single image. So this is corrupted by autofluorescence from other ocular structures, anterior and posterior to it. So you get a little bit poor resolution as compared to a Heidelberg, which is a CSLO. Here the excitation, based on the make of the camera, the wavelength varies and the barrier also varies. Essentially both these give similar images, but like we cannot compare them systematically. The images I show are from a regular fundus camera. So when you take an autofluorescent image of a normal fundus, how does it look? The disc, the blood vessels in the fovea look a little dark, and this generalized whiteness what you see is the normal autofluorescence. Parafovea gives a little bit more autofluorescence than the fovea, but it's still less than the peripheral retina. So here you see a patient with foveal aplasia. As I mentioned, you have to strain a little bit to see the images. So you don't see the distinction of parafovea and fovea here. Everything looks a little bit granular, irregular autofluorescence here. So when is autofluorescence decreased? Whenever there is atrophy of retinal pigment epithelium, the fibrous scar or melanin pigment migration. So here we see a patient with retinal pigment epithelial atrophy or choroidal atrophy. You can see this is the normal autofluorescence, but here it is lesser. And pigment again blocks it. You can see the areas of pigmentation quite clearly, blocking the autofluorescence. Hemorrhages and soft exudates also block the autofluorescence. So this is a soft exudate, hemorrhage, you can see correspondingly lesser autofluorescence. This is the normal autofluorescence we see in the background. And in contrast, whenever there is accumulation of lipofuscin, you get increased autofluorescence. And this accumulation of lipofuscin is a common downstream pathogenic mechanism in many of the retinal diseases, particularly AMD, inherited retinal dystrophies. We will be seeing these in the next few slides. So there is age-related macular degeneration. Autofluorescence is of particular importance in geographic atrophy. So it precisely maps the areas of geographic atrophy. As you see here, what we see in the fundus image is corrupted by all these colorful images, but like you see here, much more areas. You see these areas which are not well defined on the color fundus photograph can be seen very well in the autofluorescence image. So it tells us how the disease is progressing towards which direction. And if you see this border, so it initially has increased autofluorescence because lipofuscin accumulates in those RPE cells which are dying. Then subsequently those RPE cells die out and it's replaced with geographic atrophy and decreased autofluorescence. So the border at which it's progressing has initially increased autofluorescence, subsequently followed by RPE atrophy and decreased autofluorescence. So in early AMD, this is what we looked at was geographic atrophy. In early AMD, autofluorescence has variable appearance, demonstrate widespread disease not imaged with fundus photograph, and these are the patterns described. I will not be going into the details of that. So if you look at a drusen, how does drusen look? Drusen has a central low autofluorescence. You see this literally a low autofluorescence surrounded by a ring of increased hyper autofluorescence. So once atrophy happens, this increase goes down. So drusen, this is how it looks. In the pigment epithelial detachment, there is increased autofluorescence. So you see the pigment epithelial detachment here surrounded by a less autofluorescent halo. But doesn't tell us if this PED is because of CNVM or TCV or whatever. Classic CNVM, there is focal hypoautofluorescence. In occult, there may be a normal autofluorescence also. Long-standing CNVM, decreased autofluorescence corresponding to retinal pigment epithelial atrophy. Abnormal for the fundus autofluorescence area extends beyond the visible CNV. So here we see an area of decreased autofluorescence, but in the center you see an area of increased autofluorescence. This is because of collection of fluid. Otherwise you see decreased autofluorescence in a CNVM. Another very, very important area where autofluorescence helps us is in inherited retinal diseases. You see these dramatic images in diseases such as Stargardt's disease, where there is accumulation of lipofuscin. So whenever you see this yellow flecks, where there is accumulation of lipofuscin, you see increased autofluorescence. And once the retinal pigment epithelium dies out and becomes atrophic, you see decreased autofluorescence. So this is a much more progressed disease where the retinal pigment epithelium has died out. You see much severe disease, severe areas of decreased autofluorescence. It just kind of indicates the health of the retinal pigment epithelium. So what is this? Very classic. Accumulation of lipofuscin, yes, best disease. So you see this pocket of, you see this pseudo-hypopyon kind of an appearance. Accumulation of lipofuscin shows up brilliantly on the autofluorescence images. So you have the autofluorescent egg yolk, and the vitally eruptive stage, this autofluorescence is dispersed, and atrophic stage once again autofluorescence decreases. In Retinitis Pigmentosa, there is a parafoveal ring of hyperautofluorescence. You see this parafoveal ring. In the center there is hypo, and this ring constricts over time as the retinal pigment epithelium dies out. And if there is CME in the center, you may have increased autofluorescence. Other inherited retinal diseases, autofluorescence helps us towards early diagnosis. For instance, if you look at family members, say for instance this is a patient and this is an autofluorescent image, but this is a family member. When you look at the color photo, it looks almost normal, but if you take an autofluorescent image, you show that like this patient is developing the disease, which may show up in the subsequent years. So early diagnosis, autofluorescence can be imaged, can be used. You don't have to do an angiogram or an electrodiagnostic test. There are other situations like choroidal hemangioma. This is accumulation of fluid. So this is the choroidal hemangioma, but in contrast you see the subretinal fluid is extending until here. So what we see is because of accumulation of fluid, there is like lipofuscin accumulation. So this patient may have an impact on the vision because RP is not healthy out here. Similarly, this is a resolved exudative retinal detachment. You see a lot of lipofuscin accumulation under this subretinal space, again may have an impact on the vision. Myopic macular degeneration helps us to precisely map the areas of RP atrophy. If you see here, the fovea is looking normal here, but if you do the autofluorescence image, you can see the atrophic areas here. So this may explain the scotoma the patient sees and subsequent decrease in vision. In parafoveal telangiectasia is another area where autofluorescence is playing a big role. So this is the early phase angiogram of a patient with early type 2 parafoveal telangiectasia. Here you see this is the autofluorescence increased in the parafoveal area. So it is a normal fovea. If you see here, the fovea is masked by macular pigment, and this macular pigment is lost in parafoveal telangiectasia in the early stages. So you see increased autofluorescence. And autofluorescence is supposed to be one of the early signs of early PFT. So even before an angiographic sign occurs, you can do an autofluorescent image and diagnose PFT. So this is the same thing in blow-up. You can see that there is a masking of the central foveal reflex, but here it is revealed. That is because of atrophy and loss of macular pigments. So this is a much more established PFT. You can see the accumulation of fluid shows us as increased autofluorescence, and rest of the area is decreased autofluorescence. And with choroidal neovascular membrane, again the picture changes. You see on color photograph much lesser area of involvement, but on the autofluorescence image you can see a much larger area of involvement. So chorioretinal scar bullseye, otherwise you have these inherited diseases which can present as bullseye. Again, you have an area of decreased autofluorescence in the center surrounded by a ring of increased autofluorescence. In central serous retinopathy, the area of leakage shows hypoautofluorescence surrounded by an area of increased fluorescence because of accumulation of fluid. And chronic CSC, you can see the RP tracks and the RP being not very healthy because of the accumulation of this lipofuscin. In choroiditis, it helps us to diagnose the extent of the disease much earlier. And as you can see here, color photo does not reveal the true extent of the disease, but here it does reveal the true extent of the disease. To summarize, autofluorescence helps us assess integrity of retinal pigment epithelium and photoreceptor complex in CNV, choroidal inflammation and ICSC, aids early detection of some inherited retinal disease. It's a prognostic marker for vision in AMD, reveals true extent of the disease in many of the retinal diseases, and complements existing fundus imaging and should not be seen in isolation. Thank you very much.